gotten into that. Oh, look up here on the monitor. You just found that second orifice. Good job. Hi, welcome to Ruddle on Retreatment. In this episode, we'll be dealing with coronal disassembly, missed canals, and how to properly communicate with the patient in the retreatment situation. A little later, I'll show you how to schedule retreatment cases and structure fees for these procedures. Many significant advantages result when failing endodontic cases are non-surgically retreated. Disassembled teeth can be evaluated for mechanical failures, micro-leakage, fractures, missed canals, pathologic and iatrogenic problems, and importantly, these root canal systems can be recleaned, reshaped, and repacked in 3 dimensions. In fact, most endodontically treated teeth that exhibit post-treatment disease can be successfully retreated non-surgically. When confronted with endodontic failure, clinicians must select the best, most predictable treatment approaches which will provide long-term success. How do we do this? Let's look at a list of issues that should be considered when choosing between retreatment or extraction. First, what does the patient want? It is profoundly important to understand the patient's needs, wants, and what their overall expectations are related to their oral health. Second, is it a strategic tooth? Clinicians need to look very carefully at any particular tooth that is failing endodontically and decide, is this a critically essential tooth to optimize oral health, or are alternatives to endodontic retreatment more predictable? Third, non-surgical root canal treatment versus surgical root canal treatment. Endodontic failures must be carefully evaluated so a decision can be made between non-surgical root canal treatment, surgical root canal treatment, or extraction. Surgical techniques are restricted in eliminating pulp, bacteria, and related irritants from the root canal system, but at times are appropriate in exquisitely restored teeth with apical pathology. Fourth, restorative evaluation. Fundamental to endodontic treatment is the ability to produce an aesthetic, well-designed, and clinically functional restoration that promotes a healthy periodontium. Broken down teeth should be evaluated for crown lengthening procedures so the restorative dentist can achieve the ferrule effect and a healthy biological width. The value of any tooth is only as good as the sum of its interdisciplinary parts. Certainly, it is valuable and at times critical to obtain additional opinions from the members of the dental team, such as the potential for orthodontics, prosthetics, or implant dentistry. Each discipline must be viewed separately, then collectively before instituting any treatment. Fifth, periodontal evaluation. In simple terms, practitioners need to know a great deal about the supporting tissues and their health or potential for health. Periodontal treatment can provide numerous possibilities that, in concert with other disciplines, can afford excellent longitudinal success. Sixth, training, experience, and technology. In evaluating teeth for endodontic retreatment, it is essential to appreciate there's never just one problem to overcome, but a series of challenges that must be addressed to produce successful outcomes. Clinicians must honestly evaluate, do I have the training, experience, and technology to disassemble this tooth and then prepare it for 3-dimensional cleaning, shaping, and obturation? When considering endodontic retreatment, clinicians frequently encounter a variety of different restoratives such as crowns, bridges, or long-span splints. Regardless of whether we access through, sacrifice, or remove a restorative, we need straight-line access, divergent axial walls, and an access preparation where the orifices are just within this outline form. The dental operating microscope is a critically essential part of the armamentarium in non-surgical retreatment. In my experience, Carl Zeiss has a line of superior products. Specifically, the Pro Ergo has magnetic clutches. This feature, in conjunction with rotatable and inclinable oculars, allows us to get into great position for patient care. Doctor stools are important with the armrest feature because it allows us to have shoulder support and lumbar support so we can be comfortable during our procedures. The pistol grip handles allow us to adjust the light intensity, focus, and the zoom feature. The P5 piezoelectric ultrasonic unit provides unmatched power when performing endodontic treatment and retreatment procedures. This unit affords precise working accuracy and a broad power range, and its unique feedback system enhances safety by automatically regulating tip movement. The Pro Ultra Endo 1 through 5 tips are made of stainless steel and then externally coated with a zirconium nitride abrasive. These ultrasonic instruments can be introduced into small spaces while enhancing vision, improving performance, and expanding clinical possibility. The zirconium nitride coating enhances durability and enables the instruments to sand away materials during endodontic treatment and disassembly procedures. The Pro Ultra Endo 6, 7, and 8 ultrasonic instruments are made of titanium to provide clinicians with thinner diameters and longer lengths as compared to the Endo 3, 4, and 5 instruments. As in all endodontic retreatment situations, the clinician should have a variety of rotary cutting tools that will be helpful in dealing with crowns, bridges, and completing straight line access. When evaluating an endodontically failing tooth for non-surgical retreatment, a decision must be made whether to access through, sacrifice, or disassemble the restorative. Generally, clinicians prepare the access cavity through a restoration if it is judged to be functionally designed, well-fitting, and aesthetically pleasing. Let's look at an access cavity of a maxillary molar. This first molar has a sinus tract that is being traced with a gutta-percha point. Notice the crown extends gingivally, and we cannot visualize the pulp chamber. Access cavities need to be well planned so that we can avoid iatrogenic events. We've isolated the tooth, and we're looking at the occlusal view of a porcelain fused to metal crown. The outline pattern guides our clinical actions, but in a maxillary first molar we need to be aware of the presence of an MB2, which is present clinically over 90% of the time. Therefore, the access cavity needs to be expanded at the expense of the mesial marginal ridge. A number 4 round burr diamond with voluminous amounts of water helps us make a safe window through the porcelain. A transmetal burr can make a window through the underlying metal, and then we use a surgical length round burr to drag up and de-roof the pulp chamber. Surgical length diamonds true up the axial walls and make them nice and flat so light can refract off them. GGs are ran at 750 RPMs to marry the axial walls to the orifices. Ultrasonics precisely sands away minute amounts of tooth structure and helps us find the MB2. Irrigate to flush out the pulp chamber. Notice how the tin file slides effortlessly down the mesial axial wall and into the MB2. Following ultrasonic work, you can see that we've improved access by noting the positions of the handles of the 10 and 15 files standing up straight and tall. We'll look at this case a little later, as the anatomy within the MB root was quite interesting. Depending on clinical circumstances, inlays, onlays, crowns, bridges, splints, copings, and superstructures are sacrificed and removed by sectioning with a transmetal cutting burr. In some instances, if we need to have better access into pulp chambers, crowns have to be sacrificed. A transmetal cutting burr can be laid over on its side and can begin to section the crown from the central pit area out to the buccal surface. What we want to do is carry a slot across the top of the tooth. Once the slot has been created, then what we're going to be able to think about is placing a crown splitter into this groove. Be careful to stabilize the burr and have a good fulcrum because you don't want to skate off the tooth and inadvertently injure the patient. Assess your sectioning and make sure you're completely through the metal from the buccal to the lingual. If that's the case, then the sectioning tool can be placed in between the mesial and distal halves, and then we can generally dislodge one or both halves. The crown splitter has a wedging device at its working end that, when activated, will effectively dislodge most restorative segments. Carefully insert the instrument and with handle pressure, you can generate the dislodgement force. Typically, one half will stay, so ultrasonic energy is very useful to vibrate and dislodge that piece. On some specific occasions, it may be desirable to preserve and remove existing restorative dentistry. If the dentistry meets or exceeds the restorative criteria for excellence, then the decision to remove any restoration is based primarily on the access required to facilitate endodontic disassembly and retreatment. Clinicians must consult with their patients and clearly define the risk versus benefit when considering the intact removal of existing dental restorations. We'll talk more about that later. Right now, I'm going to show you my preferred instruments for removal of restoratives based upon more than 2 decades of clinical practice. Now, these aren't the only tools used for disassembly, but the most predictable ones I found. In general, restorative removal devices can be divided into 3 categories: grasping, percussive, and active instruments. Let's look at the grasping instruments I have found most useful. The Winman Crown Gripper is designed to remove provisional crowns and metal castings that are temporarily cemented. This instrument is powerfully constructed to provide a superb grip. The working end of the Winman Crown Gripper is ergonomically curved to facilitate access and has tungsten carbide inserts. Place the Winman Crown Grippers below the height of contour. Place an index finger just anterior to the crown to be removed and fulcrum off the finger. Subtle buccal lingual rocking motions generally removes the crown. KY pliers are excellent for removing provisional crowns and bridges that are temporarily cemented. The compressive jaws of the instrument have a waffled metal grid that provides a strong and stable grip for removing temporized resin crowns. Small facial lingual micro movements facilitate the safe removal, and care should be taken not to apply too much pressure to the handles of the plier, as the provisionalized resin crown can be damaged during the removal effort. For removal of cast crowns or tooth-colored restoratives, rubber packings are inserted on the compressive jaws of the instrument to protect the surface of the crown. The rubber packings can be dipped in emery powder to reduce slippage and encourage a sure grip. Ideally, the jaws of the instruments are placed below the heights of contour on the buccal and lingual surface of the restorative. Squeeze the handles of the plier firmly, and then use gentle micro movements and progressively rock the restoration buccal to lingual. Repeated and controlled movements breaks the luting agent between the tooth and the restorative. The Crown-O-Matic affords the clinician an innovative instrument and relatively reliable technique for removing fixed restorations. This instrument has interchangeable tip inserts and provides a technical advancement in crown and bridge removal. In this disassembly technique, the clinician selects a specific tip which is inserted and tightened. 3 rings represent progressively increasing power intensities and can be selected by pushing the distal end of the instrument proximally. By compressing the trigger, the insert tip is activated and moves 1/2 millimeter. In the clinical situation, the appropriate tip is placed just mesial to the posterior abutment. The finger is applied for safety. It is important to apply steady pressure with the device on the engaged restorative while activating the trigger. Now that the bridge is loosened, the crown placer remover with rotating grippers is selected to cushion and protect the bridge. The grippers are best positioned below the buccal and lingual heights of contour to facilitate retention during the removal process. The CoronaFlex is an air-driven device for the removal of full crowns and bridges. There are several intermediary devices, such as special pliers, a loop holder with loops, and variously sized clamps, all of which are used to engage the restorative. The power intensity of the CoronaFlex is determined by turning the knurled screw knob clockwise, which increases the magnitude of force to the hammer. Brushing a finger across the activating trigger delivers intermittent pulses of air to the hammer. The hammer delivers effective energy as it accelerates over a short distance. A loop is selected and is passed under the solder joint and is positioned as close as possible to the abutment tooth. Each end of the loop is firmly attached to the loop holder. Anticipating the path of removal is critical and allows for correct positioning of the hammer against the loop holder in preparation for trigger activation. 4 to 5 pulses of air are delivered before moving the loop anteriorly and repeating the process. Crowns and bridges retained with zinc phosphate cement are the easiest to remove. With experience, bonded restoratives can also be removed. The Klein Crown Remover is a plier that can generate opposing pressure to lift off and remove posterior crowns and bridges. This device requires the clinician to drill a hole slightly larger than the swivel pin, or approximately 2 millimeters in diameter, through the occlusal surface of the restoration. Ideally, the hole is located over either the buccal or lingual cusp where there is solid tooth structure. The plier features an adjustable swivel pin which can be conveniently rotated depending on whether the removal effort will be conducted from the buccal or lingual aspect of the restoration. The swivel pin is inserted through the hole in the crown so that the removal forces are directed down the long axis of the tooth. To ensure a stable and strong grip, place the removal tip below the height of contour. Gently squeezing the handles of the Klein plier will generate sufficient opposing pressure and typically will lift the restoration off the tooth. The metal lift system is one of the most passive methods for removing crowns, inlays, onlays, implant prosthesis, and fixed bridges. There are a number of variously sized burrs that are used to cut precise holes through a prosthesis to facilitate the introduction of either the regular or magnum metal lift device. Now we're going to remove a porcelain crown with the metal lift system. The self-contained kit provides all the rotary cutting tools you will need for this procedure. The diamond burr is used to penetrate the porcelain layer until the underlying metal is observed. Next, the small carbide round burr is used with a light touch to penetrate the underlying metal. The parallel wall drill is then selected to machine a precise opening to specifically match the metal lift removal instrument. With the drill removed, we can see that we have created a precise channel. In this instance, the magnum instrument is introduced into the machined opening to tap and thread the metal portion of the restoration only. The handle is turned in short clockwise rotations, which will push the distal end of the instrument against dentin. This action will generally break the cement bond and lift off the restoration. In some instances, if this tool strips the threads and pulls out, another hole can be made at another location on the occlusal surface to facilitate the removal process. Endodontic prognosis is maximized in teeth whose root canal systems are clean, shaped, and packed in 3 dimensions. A missed canal can change that prognosis. The etiology of endodontic failure is multifaceted, but a significant percentage of failures are related to missed canals which potentially harbor residual tissue, bacteria, and related irritants. There are several tooth groups whose roots frequently hold extra systems. When we encounter these teeth for retreatment, a red flag should go up and we should be on the lookout for missed canals. In the maxillary arch, an occasional extra canal or canals is noted in the central incisor. Maxillary first bicuspids generally exhibit 2 roots and related root canal systems. The clinician should anticipate multiple portals of exit over the length of the canals. Some of these systems have deep divisions. Fused roots oftentimes have ribbon-shaped orifices. Within the body of the canal there can be deep divisions. At times, maxillary first bicuspids can have an MB, a DB, and palatal roots. The maxillary first molar has two systems in the MB root about 90% of the time clinically. About 40% of the time, the two systems merge and exit as one apical portal of exit. In about 60% of the cases, the two canals are separate and have their own individual apical portals of exit. Some maxillary molars can exhibit bizarre anatomy within the MB root. The grooves need to be explored for the possibility of a third system. Access cavities need to be fully expanded, so we have the possibility to identify, in this particular case, DB1s and 2s, MB1s and 2s with a long anastomosing, and there's two palatal systems. Even the maxillary second molar should be expected to have two systems in the MB root until proven otherwise. Mandibular incisors have broad roots facial to lingual and have a second, more lingual canal approximately 45% of the time. The post-op film demonstrates this concept. Mandibular bicuspids have roots that frequently hold complex root canal systems. The anatomical variations include two or more canals that divide at various levels within a generally fused root form. Mandibular bicuspids are known for bizarre internal anatomy, including simple kinds of systems, displaced orifices, deep divisions, loops and branches, and multiple apical portals of exit. Mandibular first and second molars routinely have significant variations within what has become known as normal anatomy. Clinicians need to check the mesial root for a third system, which is occasionally located within the groove between the MB and ML orifices, or it may be displaced. The broad distal root commonly contains an extra canal which may be separate along its length or become contiguous following the cleaning and shaping procedures. C-shaped molars are named for the cross-sectional morphology of their roots and the internal configuration of the root canal system. Additionally, C-shaped molars have fused roots, deep pulp chambers, and a cul-de-sac furcation towards the lingual aspect. These teeth pose challenges in endodontic treatment, and clinicians need to be familiar with this aberrant canal form, its radiographic features, and its incidence within the various population groups. Now that we've developed the anatomical roadmap for the various teeth, we can better evaluate the cause of failure. Let's examine the tools that will help us find missed canals. Clinicians should take 3 well-angulated radiographs prior to initiating treatment in order to better appreciate the three-dimensionality of any given tooth. From an endodontic standpoint, preoperative films should include mesial, distal, and straight-on angles. These views will better prepare the clinician for root canal treatment. 3 films in combination are more valuable than a single film alone, and give us important information as to the buccolingual dimensions, concavities, and extra canals. Magnification glasses and operating headlamps are most useful when performing endodontic retreatment. Different magnifications afford different powers and provide the clinician with clarity when doing procedures deep within the root canal system. Transilluminating devices are an important adjunct to good vision. Dental auxiliaries need to be trained to hold the fiber optic wand either above or below the rubber dam to play the light buccal to lingual to enhance vision. With the overhead light and the microscope light both turned off, transillumination gives us a wonderful perspective of the MB1 and related groove in this maxillary first molar. The dental operating microscope provides unsurpassed vision when performing clinical tasks. Aside from remarkable vision, the microscope allows our posture to be correct, and we can work for extended periods of time. In endodontic retreatment, the clinician will require a number of rotary cutting burrs. In particular, the surgical link burrs move the head of the handpiece away from the occlusal table and provide unsurpassed vision when chasing missed canals. The P5 piezoelectric ultrasonic unit provides unmatched power when performing endodontic treatment and retreatment procedures. This unit affords precise working accuracy and a broad power range, and its unique feedback system enhances safety by automatically regulating tip movement. The Pro Ultra Endo 1 through 5 tips are made of stainless steel and then externally coated with a zirconium nitride abrasive. These ultrasonic instruments can be introduced into small spaces while enhancing vision, improving performance, and expanding clinical possibility. The zirconium nitride coating enhances durability and enables the instruments to sand away materials during endodontic treatment and disassembly procedures. Micro openers provide 3 instruments for initiating treatment in missed canals. Offset handles enhance vision, and 7 millimeters of cutting blades in conjunction with double and triple tapers enhance rigidity. Here's why I like the micro opener in the difficult to find canal case. Broad roots oftentimes hold more than one system. Oftentimes the division is far below the level of the orifice. Typically, handles and fingers that engage those handles block and limit vision, and even when you can begin to get into the canal, oftentimes the instrument collapses as it is too thin in its taper. A micro opener has an offset handle and can be pre-curved, and because of their double and triple tapers, they afford the rigidity one needs to begin to move into these canals. Properly curved and a few short pull strokes begins to remove restrictive dentin. A few more strokes begins to improve the glide path. Gates liddens can now be used to flare the orifices. This facilitates the subsequent introduction of small hand files. There are a number of strategies that, when used in combination, greatly increase the identification of additional systems. The more useful techniques are summarized here, and the clinician should keep in mind that at times, certain treatment modalities are more appropriate for a particular tooth. This maxillary central incisor appears to have one canal. Notice how the obturation material is centered in the root. If we move the X-ray cone about 15 degrees, you can see asymmetry suggesting a missed canal. Typically, when we're looking for missed canals, if we can get the crown off the tooth, we're going to have better visibility. We'll be able to see the circumferential dimensions of the tooth and how it moves into the gum line. It's helpful to use surgical length burrs. In this case, a surgical length burr kicks the head of the handpiece further off the occlusal table, and that gives us a line of sight along the shaft of the burr. Notice how at all times we can watch the tip of the burr or its bud turning and cutting. This means we're in charge and we have control of the case. Typically, as we work deeper into the tooth, you can see that moving patients' heads subtly allows us to keep that line of sight. We need to be able to move the patient's head so we can keep the handpiece away from our line of vision. The surgical length burrs brush gently away on the restoratives, and oftentimes as you get closer to the pulp chamber floor, one has to run the RPMs a little bit slower so we can kind of work our way down to the gutta percha. I think you can begin to see a little pink, and that's always a good sign for a clinician because it means you're on track. Here the explorer can chip away and start cleaning up the axial walls so we have a good line of sight, and we can begin to look at the gutta percha and see where it's positioned between the facial and lingual walls. In that particular view, it almost looked like it was centered, but because of our confidence with our radiographic examination, we know to chase and look for the missed canal. We even know from our preoperative radiographs that the missed canal should be lingual. Surgical length diamonds true up axial walls, and flat axial walls refract light better to the observer. This means our vision's enhanced. With that wall trued up, you can begin to see a little bit of indication of some material or the suggestion of a second orifice. Notice how we carry that wall to the lingual. We can begin to see that it makes sense that that orifice would be there because it's about evenly centered between the lingual and the orifice containing gutta percha. Now, as we begin to dress up the gutta percha and get it a little bit below the orifice, this will give us a better path of the floor, and colors are very useful to give us confidence to chase. Ultrasonic instruments provide phenomenal breakthroughs because they can brush cut, their scale geometries reduce the size of the instrument so it's more proportional to the work at hand. and very rapidly you can see we're into an orifice and beginning to find the opening to that root canal system. It's very useful to work dry. Assistants can blow air and it's collimated into the tooth so that at all times debris and dust is liberated from the chamber. This allows us to have a continuous line of sight into the area where we're working. I like to use Gates Gliddens on those little small orifices and face off the orifice so there's a great smooth transition down that axial wall from the incisal reference point into the pulp chamber space. Irrigation sets the stage for getting the file into the right canal, and once we can slide down that wall and get into the orifice, we can begin to notice a little handle flutter, and this typically suggests we're beginning to track the system. Obviously, radiographs are going to be useful to confirm that we are in a missed canal, and the radiograph confirms the second system. Another important idea for locating canals is to carefully probe the sulcus. This can give us important information as to the relationship between the long axis of the clinical crown and the underlying root. This maxillary first bicuspid is the anterior abutment of a 4-unit bridge. If you look carefully, you can notice there's a deep pulp chamber just below the margin of the restorative. Further inspection of the film reveals 3 separate roots. With the bridge removed, the tooth isolated, and the access preparation completed, you can visualize the smaller and slightly displaced MB and DB orifices. Small handle reciprocation moves the file in, and handle flutter suggests the tip of the file is beginning to bite and track the canal. Clinically, I would want viscous chelator in the chamber to act as a lubricant, which would help the file slip and slide deeper into the canal. It's convenient to insert both instruments, so that when a film is taken, you get information regarding both canals. The post-op film demonstrates the endodontic procedure, conservative shapes in the MB, DB, and palatal systems, and that the bridge has been re-cemented into place. Maxillary second bicuspids can have broad roots and commonly hold 2 canals. You can see in the mesial angle there's asymmetry between the gutta percha and the lateral walls of the tooth. Again, it's always wise to try to get a crown off a tooth to enhance vision. The KY pliers with their rubber pads in emery stone give us a strong purchase so that we don't dangerously slip off the tooth. Try to isolate your teeth as close to the free gingival margin as possible. This exposes as much tooth structure as possible so you can get a better read on the anatomy of the clinical crown. Surgical length round burrs are again utilized because what we want to do is have maximum vision. Their extended lengths moves the head of the handpiece further away. Notice that we found gutta percha towards the buccal. Because the gutta percha is skewed to the buccal, it suggests to the clinician to move the access more to the lingual. Of course, the preoperative films guided our pathway and let us know where to look. Look at the characteristic outline pattern in that axial wall. You can tell that's where the pulp used to be. So that's pulpal space that's probably filled with some debris or maybe a shard of calcific material like a stone. Surgical ink diamonds true those walls up, and again, flat, smooth walls refract light and enhance vision for the clinical team. Notice the symmetry between the orifices and the cavo surface. Here, an Endo 3 parallel-walled ultrasonic instrument is used. Its zirconium nitride coating allows it to delicately sand away minute amounts of tooth structure in a very controlled fashion. Face off the orifices with small Gates Gliddens. If the orifice is restricted in diameter, it's okay to face off with perhaps a 1 or a 2 GG, and that'll create a guide path for a larger Gates Glidden. Move the head of the handpiece around from different angles to smooth up and true that orifice level up. Now we're coming in with like a 5 Gates Glidden, and notice that begins to really true up the axial wall. The goal is to have a smooth axial wall so instruments can slide passively through the access cavity into the orifice. Normally, pulp chambers would be topped off and brim full with irrigant. For teaching purposes and for enhanced viewing, the tin file is placed into a dry chamber. Notice the post-operative film and the symmetry. Maxillary first molars notoriously hold a second system in the MB root about 90% of the time. Therefore, off-angled films begin to show us the breadth of the root and the asymmetry of the gutta percha within the MB root. Picking the access up in progress, you can see the same kinds of attention to detail needs to be followed from case to case. We need to disassemble and remove all the previous restoratives. Getting the restoratives out of the tooth is going to give us the vision we're going to need to begin to chase for extra canals. In this instance, it's good to use the surgical ink burrs because, again, they provide better vision, and ultrasonics disintegrates and blows out a lot of this debris very rapidly and very safely. Notice the great vision you have lateral to the instrument instead of looking at the back end of a handpiece. True those walls up as per usual because, again, it refracts light and we can begin to get a better sense of the anatomy off the pulpal floor. I like to take the gutta percha just a little bit suborifice level, just bump the rheostat and get a little rotational speed, being careful not to cut dentin. And by removing gutta percha and getting it off the orifice levels, you begin to see the pulpal floor in its entirety, and you can begin to appreciate the relationships between orifices. Now, a lot of times we've been trained to look for the MB2 on an imaginary line between the MB1 and the palatal. And although frequently there is a groove there, and firm explorer pressure can be used to lean on it and see if you can pop through a roof of overlying dentin, we have to be aware that orifices can sometimes be displaced, and in this instance it looks like there's some material very close to the palatal system. In fact, this material may be there resultant to the pack on the original case. But we can begin to work on this area with ultrasonics and very carefully sculpt away the material. Notice the color distinctions between the pulpal floor and the axial walls.
A very small, progressively less tapered instrument like an Endo 4 can be used.
Notice its small profile gives us incredible control and vision when minutely and discreetly brush cutting away material. Air blows out the debris and gives the operator continuous vision. The micro opener is an excellent instrument and can be used to begin to open up the mouth of the canal. Moving the instrument and cutting towards the buccal and then cutting a little bit towards the palatal begins to funnel the orifice level so that the instrument can proceed a little bit deeper. Again, the Gates glidens are used not to travel down the root, but just to be kept and limited to the level of the orifice. By facing off the orifice and removing more restrictive dentin, the micro opener can now pass in deeper. It has 7 millimeters of cutting blades, and you can see that virtually all the blades are below the pulpal floor. This means we're clearly in the coronal 1/3 of the root. Typically, I'd like to have irrigant in here at this time, but for teaching purposes, I want you to see how effective the micro openers are on the pulse stroke. They can be used very vigorously because of their larger cross-sectional diameters. Irrigate these teeth and flood them with solution. Sodium hypochlorite is a good lubricant, helps instruments slip and slide to length and negotiate canals. In the mesial angle, it would appear the MB2 is contiguous with the MB1, but the distal angle shows that it's separate over length. In this lone view, this maxillary first molar appears to have 3 roots. Let's re-enter the tooth and check out the pulpal floor. The concepts previously described are important in terms of having smooth axial walls. Pulpal floors of fricated teeth frequently hold important information. Notice the dark organic lines that we can see moving between the gutta percha-filled orifices and something off towards the distal lingual. Ultrasonics can very easily sculpt away material, and you can see that we're already starting to move into a canal. Its mouth is opened with a micro opener, and again we can follow these landmarks and they can very precisely and predictably carry us into missed canals, or in this instance a missed root. It's a big system. It's the distal palatal root, and the tin file easily moves to place. Inspecting the extracted tooth begins to reveal not only then are there extra canals within single roots, but we can even have extra roots. A radiograph of maxillary first molar suggests that the tooth is more simple than it really is. Again, ultrasonics can be used to blow out previously placed restoratives in the pulp chamber. Access is expanded and irrigation is very useful to flush out debris. Oftentimes, if you look very carefully into a tooth that's brimful with irrigant, bubbles can be seen emanating towards the occlusal table. When bubbles are noted, it usually means in this instance that sodium hypochlorite is reacting with tissue and it's liberating oxygen. The champagne test then can be used as a canal indicator. Solvent-filled canals are an opening for negotiating root canal systems. A working film shows the instrument at length. Oftentimes, a lip of dentin meets the pulpal floor and forms a groove. Many colleagues are probing tenaciously in this groove to find the MB2 system, but it needs to be recognized that the second canal is under this lip of dentin, and this lip of dentin needs to be removed with ultrasonics. In this graphic, we can see this shelf of dentin is oftentimes formed by the abrupt angle where the MB2 canal enters the pulp chamber floor. Clinically, when we use ultrasonic instruments, they generate debris. We call it the white line test because in necrotic teeth, dental debris moves into the isthmus area and makes a white line. When we track the white line, it will roadmap and lead us to the MB2. In vital cases, blood will frequently move into these isthmus areas and can be used as an indicator where the underlying anatomy is positioned. Notice the MB1 and related groove, but notice the long groove off the DB. We call this the red line test. With careful resection and identification and thorough cleaning and shaping, the post-op film reveals an MB1, MB2, DB1, and DB2, and a palatal system. 5 systems in this maxillary first molar. Here's a straight-on radiographic view of a maxillary second molar. Notice that the roots are fairly short. In the distal view, it throws the buccal roots anterior, and notice how complicated the roots appear over length. This would be a good time to show the power of transillumination. Once the access has been roughed in, ultrasonics is employed to begin chasing along the groove that emanates off the MB1. Recall the breadth of the MB root in its buccal lingual dimensions and notoriously having the furcal side concavity. If we turn the overhead light off and turn our microscope lights down, assistants can hold the fiber optic wand either below or above the rubber dam and play the light into the tooth perpendicular to the long axis. We can work in these conditions very safely and get a nice perspective, a different perspective, if you will, from typical lighting. Solvent-filled canals begin to show us the anatomy as it bleaches tooth structure and removes organic debris. Notice the arc of that isthmus area, reflecting the external surface of the underlying root. The working film shows the instrument moving through multiple planes of curvature and at length. When accessing mandibular incisors, we need to always be aware of the possibility of an extra canal. Microsonics is a combination of ultrasonics and magnification with the microscope, and this affords unsurpassed vision when working in these very small teeth. The canal that's typically located is the facial branch. The one that we usually don't find and the one that we should suspicion is more lingual. Therefore, access cavities have to be drugged towards the lingual at the expense of the cingulum. Recall that the root of the lower incisor is inclined to the lingual, so we can safely carry the access in this direction. Getting a catch with an explorer permits a Gates Glidden to come in and face off the orifice. It's very important to understand and appreciate that we can use Gates Gliddens 4s, 5s, and 6s if they're confined to the pulp chamber. This creates a very smooth glide path and gives us a straight line access into this more lingual displaced branch. When a tin file stands up straight and tall, it confirms both coronal and radicular straight line access. As a group of teeth, mandibular bicuspids notoriously hold internal bizarre anatomy. Frequently, radiographs reveal one root, but oftentimes these roots are very broad buccal to lingual. Access into these teeth is straight line, but a lot of times we're working so far below the occlusal table that access cavities have to be further expanded to provide deep views. Remember, an expanded access cavity isn't just for the convenience of the operator, but it gets more light deep in the tooth so one can see. The clinician has permission to move access cavities closer to the cavos surfaces if, in fact, multiple preoperative radiographs suggest an aberrant root form. This little orifice or system may be contiguous with the previously packed canal, or it may represent another entire canal, whereas this more mesial lingual system suggests it's a separate independent root. If we observe the tooth in our hand, it's kind of sobering sometimes that we have as much success endodontically as we do. This emphasizes the importance of multiple preoperative views. Here's another mandibular bicuspid. Notice the importance of straight line access. Notice how the walls are smooth and flat and flare out from the pulpal floor towards the occlusal surface. With improved access, it's not too difficult a lot of times to find the extra orifice or catch. In this case, it's displaced far towards the mesial and the lingual. We've talked several times during this tape about the importance of facing off orifices with Gates Gliddens. This is a really important secret because a lot of times once we fill these chambers with like a chelator, our visibility is now obstructed. So now we can slide instruments down smooth axial walls into these faced-off orifices, and it helps negotiate the canals. Ultrasonics can chase out the isthmus or related anastomosing between orifices, and again with a faced-off orifice we can pretty easily slide into this system. Now working the instruments to length can be pretty revealing, because looking at the extracted tooth you can begin to see the broad root, you can see that it's a fused root, the apical 1/3 has a cul-de-sac furcation, and the system that we just negotiated has its own separate apical portals of exit. You can see the gutta percha on the more facial aspect. Mandibular molars frequently hold an extra canal in their distal roots. When we look down the access cavity, we can begin to see the treated gutta percha-filled distal buccal canal is skewed off towards the buccal aspect. Therefore, this gives us confidence to drag our access walls out towards the lingual. Now notice how there's more symmetry between the DB and the DL orifices as compared to their mesial counterparts. Having faced off the orifices, instruments can be slid into these canals. If we have straight line access, the instrument is observed to stand up straight and tall. Sometimes we have to pick through little pockets of resistance so we can fully negotiate the canal. Looking at the occlusal view of the isolated tooth reminds me of an old expression. Start with the end in mind. The outline pattern can be used to guide our clinical actions. We select a transmetal burr because we're accessing through a metallic crown. The round burr sweeps like a brush to remove dentin. A tapered diamond smooths up and refines the axial walls. Microscopes in combination with ultrasonics allows us to perform microsonic techniques. Notice the assistant using continuous air as we sand away tooth structure precisely. Notice when no air is blown into the access preparation, debris accumulates rapidly due to the cutting efficiency of the ultrasonic instrument. Use this instrument in a painting brush-like motion. Here we've uncovered an extra orifice between the MB and the ML orifices. With the tip of the file engaged, we get handle flutter. The finished access cavity can be topped off with an appropriate irrigant. This access cavity looks correct. Notice the distal orifice is uniformly centered between the MB and the ML system. Ultrasonic energy can be used to chase along the isthmus between the MB and the ML, as sometimes a missed canal can be located within that groove. Just about 2 millimeters, mesial and lingual to the ML system, is a catch. Ultrasonics removes a lip of secondary overlying dentin, and rapidly we have access to another system. Transillumination with fiber optic lights reveals this system. In retreatment, there's never just one obstacle, but usually a series of challenges that needs to be overcome. At the end of this tape, I'm going to discuss scheduling and fees so you'll have the proper chair time to be successful. A C-shaped molar gets its name because of the pulpal floor anatomy and the configuration of the orifices. Classically, a C-shaped molar will have a contiguous system from the mesial buccal along the buccal aspect of the pulpal floor and extending around towards the distal. Within this C, you may have a contiguous sheath of tissue, or you may have solid tooth structure with an orifice or two that's within this groove. The classic C-shaped molar then poses a lot of treatment challenges, and there's several distinguishing characteristics that we can notice. It's usually a mandibular molar. 2, it's usually a mandibular second molar. 3, radiographically it'll appear to have fused roots. And there's finally a dominance or predomination for this tooth in the Asian population. Because the C-shaped molar has a deep pulp chamber, which is usually subcrestal, it's a long distance from the occlusal table to the pulpal floor. In the instance of a vital case, blood may be emanating from the midst of the pulpal floor, giving the clinician insecurity as they may think they've inadvertently perforated the floor of the tooth. Working instruments along this sheath of pulpal space or tissue can sometimes be a little bit daunting in that you're not sure necessarily where the instruments are. Apex locators are useful, but radiographs are best for confirming the position of the file within the root of the tooth. Looking at the C-shaped molar extraorally reveals its anatomy. Notice the fused roots. Notice that as we move down towards the apex and turn the tooth around, we see the cul-de-sac furcation towards the lingual aspect. If we look right up on the end of the root, you can begin to see within the sheath or isthmus that follows the configuration of the root, there's gutta percha at the extents of this fin. Notice the dead space in between the two gutta percha points. Therefore, many times, the pulpal floor anatomy reflects the anatomy that we see at the end of the root. Notice the massive swelling in the buccal vestibule. The radiograph reveals incomplete endodontics, and subsequent shows will cover the disassembly effort. When we pull the post out of the buccal system, note that it is skewed off and not centered within the buccal lingual confines of the clinical crown. Moving the access lingual uncovers the lingual orifice. You can see the post-treatment effort and the sealed portals of exit, and the recall at 7 years shows the inevitability of bone fill. Here is a preoperative film of a maxillary first molar posterior bridge abutment. Notice a gutta percha point tracing the sinus tract. Earlier in the show, we actually accessed this particular abutment, and I showed you the MB root. I mentioned that it was very interesting. Let's take a look. In this straight-on view, you can see that we've pre-flared the MB canal, and now a pre-enlarged canal can accommodate a pre-curved file to length. Notice the 10 file in the distal buccal to length. In this working film, taken from the distal, you can see we've isolated the MB root more anteriorly. In a pre-flared canal, notice the 10 file working through the MB2 and to length. In another working film taken even more distally to the previous film, notice the secret to endodontic success. A pre-flared canal allows a small-sized file to slide through multiplanar curvature and to length. Notice the furcal side concavity. It's exciting to look at a post-operative film when we've completely followed and fulfilled the mechanical objectives for cleaning and shaping canals. Notice the recurvatures, the bifidity, the lateral canal, and the multiple apical portals of exit. A radiograph of an endodontically failing molar shows the previous treated canals are underfilled and underextended. There is suspicion of a second system in the MB root. The photograph at 15x demonstrates crown removal, straight line access, and the identification of an MB2 system. Another photograph shows the pulpal floor and the orifices following canal preparation procedures. Notice we removed all the gutta percha from the MB1, palatal, and DB systems. Traditionally, we've always taught clinicians that the extra canal is on an imaginary line between the MB1 and palatal orifices. In reality, The MB2 is always mesial to that imaginary line, and access cavities need to be modified accordingly. The postoperative radiograph demonstrates non-surgical retreatment has addressed the root canal systems. Here's a mandibular first molar that demonstrates multiple retreatment challenges. The metal lift can be used to remove the porcelain-fused to metal crown. With the crown off, notice the metal lift and how it mechanically removed the crown. With great access and improved visibility into the pulp chamber, notice that the distal buccal system is not centered within the pulpal floor. Access is corrected. Notice the coloration of the pulpal floor and how it takes us to the extra canal. The post-treatment radiograph demonstrates the three-dimensional pack. Here's a recall film at 7 years. Notice the inevitability of the bone to fill after complete endodontics. An endodontically failing molar shows the obturation material within the distal root not centered. A photograph at high power into the center distal orifice reveals obturation material positioned subcrustally in a fin off this canal. A working film shows a 15 file in the DL system and at the radiographic terminus. A photograph at 15 power shows a second distal lingual system. Notice the white line between the treated DB and DL orifices. The photograph at 15 power shows access to a shaped distal lingual system, a cleaned out isthmus, and the previously treated DB system. A working film shows a size medium master cone at length. The post-treatment radiograph demonstrates the packed DL root canal system. You're beginning to see in the case reviews that many of these failing cases have missed canals. Notice the radiograph of a mandibular right first molar reveals a silver point in the mesial root that is coronally foreshortened and apically overextended. As a review, you can begin to see how a micro opener can reach deep into the distal orifice of a mandibular molar and help us get to a more displaced canal. At a higher magnification of that graphic, you can begin to see the end of the instrument is just gently inserted into that branch so we can begin to remove triangles of dentin. A postoperative radiograph shows the non-surgical retreatment, a packed third mesial system, and corkage of 5 apical portals of exit. In a referral-driven practice, it's quite normal to have patients present having had previous endodontic treatment and failure because of a missed canal. But I'd like to share a case with you that I did some years ago where I missed a canal. Notice this radiograph of a maxillary right first molar and the palatal root is failing. I decided to retreat this case non-surgically because at this point in time, I now had the clinical advantage of the microscope. A photograph at high power provides a deep look into the apical 1/3 of the palatal canal and reveals sealer entering into the lateral canal that I missed. Another photograph at high power also demonstrates that the micro-opener's working end has entered into this lateral branch. The working film demonstrates the 10 file moving through this ramification to its terminus. It was exciting to see the post-treatment radiograph, which revealed that we had addressed the root canal system anatomy. This should set the stage for long-term predictable success.
Well, we've saved the best for last. I'd like to talk to you about patient communication, fees, and scheduling at the same time because they are so interrelated. If you can effectively show your patient the benefits of retreatment, half the battle is won. The idea is to shift your patient's focus from pain, emotional reactions, and financial concerns to the possibility of satisfaction and oral health. In my experience, excellent communication is fundamental. Most patients respond positively when the various treatment alternatives and their associated times and cost are discussed in a straightforward manner. From a doctor's viewpoint, the concerns are what are the technical challenges that might lie ahead, how much chair time will be required, and what is the appropriate fee that can be charged for the time spent. So the question might be, what is a fair endodontic retreatment fee? I have always felt that the fees associated with endodontic retreatment and the restoration of that tooth should equal the alternatives. Here's a great way to present endodontic fees to your patients. Patients don't have any idea what the value of endodontic retreatment does for them. So unless you create the value by telling them their alternative cost, you're not going to have as many patients accept retreatment. Typically, if an endodontically treated tooth is failing and is extracted, we do invasive procedures like preparing adjacent teeth, and we would put in a 3-unit bridge. As an example, if we charge $700 per unit, 3 times $700 would equal $2,100. Clearly, a restored implant has greater fee and more chair time required and more visits over many months to accomplish the result. So that kind of takes us back to, so what is a fair endodontic retreatment fee? If we go back to the fundamental foundation, root canal treatment plus the restoration should equal the alternative, then as an example, if we put in $700 as the endodontic fee, most endodontically treated teeth will need a post-core and build-up, and we could say, for an example, that that's about $200, and then of course this tooth needs to be restored with a crown. If you do the math and add all these up, you can see that it comes to $1,600. The problem is $1,600 does not equal the alternative bridge fee of $2,100. So what can we do about this? Well, what's missing in root canal treatment is that is a fee typically assigned for the removal of the pulp, bacteria, and related irritants. It doesn't factor into all the disassembly things that we need to do. So disassembly is what's missing, and that's what's standing between you and doing a lot of retreatment, is having the chair time and the permission to spend the time to take these teeth apart so they can be recleaned, shaped, and packed. So if we look at the formula again, we can begin to see that if we added $500 as an example and did the addition, we would then have $2,100, and now this does begin to approach the alternative treatment choices. What's missing in this equation is root canal treatment frequently implies to most insurance carriers that it's the removal of the pulp and the bacteria and the irritants through clean and shaping procedures followed by 3-dimensional obturation. It doesn't factor in disassembly. If we have the $500 as a disassembly fee, it'll give you the permission to spend the time to create great results for your patients. Assume clean and shaping procedures are complete and the master cone or cones are fitted and verified. At this point, you probably need only 10 to 15 more minutes to complete the case, but for whatever reason, the patient is rescheduled. The question is, how much non-productive time is spent rescheduling? In my experience, bringing a patient back for a second procedure requires several redundant procedures such as chit-chat. Chit-chat may be a few moments, or based on your personality, may be several minutes. Anesthesia. Giving it is not the issue, it's obtaining it. It may take several minutes to get profound anesthesia in certain kinds of cases. Isolation and reentry, although not a great amount of time, still require redundancy in procedures. Then there's reorientation. Once you get back into the pulp chamber, sometimes you'll notice exudates. Files that used to be snug apically are now loose, and it may require several instruments to get everything back like it was the last time. Now we have to verify those cones, and we have to make sure they're ready to be fit and packed. There's post-operative instructions again, and then there's more chit-chat. So you can see the 10 to 15 minutes needed to complete the case is expanded to approximately 1 hour due to the duplication of procedures when you reschedule. It might make more sense to take the extra 15 minutes required to complete the case on the first visit rather than having to reschedule an additional 1-hour session. Correctly scheduling the right amount of time is critical and can save you tens of thousands of dollars per year. So now you should feel comfortable about coronal disassembly, locating missed canals, and the importance of communication, fees, and scheduling, and how these impact the practice of success. Speaking of success, I'm reminded of a story. Some years ago, I visited South Korea as a personal guest of my former patient, Chairman Kung-hee Lee. Chairman Lee owns Samsung, which is one of the massive conglomerates recognized internationally as a leader in sophisticated semiconductors. Towards the end of my visit, I was invited to have a personal meeting with Mr. Lee at his remote retreat, where employees of Samsung are schooled in the corporate philosophy of business and human potential. I recall vividly being escorted past his famous Ho-Am Museum and up the mountain to visit him at his secluded Human Resource and Development Center. The setting elicited great inspiration and reverence. After initial greetings, we were left alone. We sat face to face for several seconds in absolute silence. As I gazed at him, I formulated my only question: to what do you attribute your great success? He slowly arose and motioned for me to follow him into the international planning room. On the expansive walls, ongoing Sansom projects were represented on large calendars that spanned several years. You could see the status of any project immediately, when it started, what had been done, and importantly, the project's completion date and integration into the master plan. He then emphasized how all projects begin with the idea, are modified by group interaction, and a strategy is developed to accomplish the goal. He stated emphatically, success requires dedication, perseverance, effort, and sacrifice. Dentistry can take a page from Mr. Lee's handbook for success. I challenge you and your team to make mutually achievable goals. Post your plan on the wall in a conspicuous place so it can be visualized daily. Teamwork is the fuel that powers success. Teamwork allows average people to accomplish extraordinary results. There's an old expression, model success, success always leaves clues. Thank you for your time and willingness to learn. I look forward to visiting you in the next episode of Ruddle on Retreatment. Set some exciting goals and have